Hi guys, happy Tuesday. Thanks for joining me in again today. Today I am going to have a special guest, and this is a topic that we have not broached before on our channel, and it's about women's health. But this is not something people usually think about when they first think about metabolic health and weight loss. They don't go straight to women's health issues. But as I've learned through my journey and through the journey of my clients, is they are very much intertwined. So a couple weeks ago, I had the pleasure of going to low carb Boca and getting some good continuing education, and had the esteemed pleasure of meeting Dr. Andrea Salcedo. She is a gynecologist, but more than that, she's also a mom of 3 young boys. She understands the struggle of what it's like to try to be healthy, juggle a career, and be a mom, and all that crazy mom stuff. And she has done a lot of extra work just on connecting insulin resistance, metabolic health, and hyperinsulinemia all to women's health issues. And I can't wait for you to hear from her. So let's welcome Dr. Salcedo to our show.
Hi. Thanks so much for having me. I'm so glad to be here. What an honor.
Well, thank you so much. So can you first just kind of give my viewers a rundown of what got you interested in gynecology, kind of your history of working through things, and then anything you might want to know about your personal journey through your women's health journey?
So, I come from a very I'm like an underserved background. Like I was, only thing I knew, and I didn't have any doctors in my family, like the quintessential aspect of being a doctor is delivering a baby, right? So I always just wanted to deliver a baby, and that was like the big thing. And I can't really remember wanting to do anything else. I've always wanted to be an OBGYN. And so when I finally got into medical school and, um, finally did deliver baby and then confirm my true passion for women's health and helping women through that really delicate process of pregnancy, labor, and delivery. But gynecology was like a really big and a kind of a space that like I didn't think I was going to be in that interested in. I actually thought I was going to be a high risk OBGYN doctor. I thought I was going to take care of women in that capacity. I still do a lot of that, but that's like a very specialized area of OBGYN. And so I actually didn't really want to take care of a lot of, periods and painful periods and pelvic pain and all of that, because the reason why is because a lot of gynecologists, myself included, have a hard time taking care of that specific subset of women because it is so challenging to treat it, because there's so many different reasons why women have pelvic pain and heavy periods and all that. And if you've been to the gynecologist in the last 10, 20, 30 years, a lot of the major modalities that we use, and not to knock it or shame it, is birth control and hormone therapy and stuff. And so, and they do help a ton, but like I personally had struggles with like infertility and endometriosis and all that. And I felt pretty bad that like after all this training, the best I could do was offer like a birth control pill or give my own, treat my own problem with birth control pills and things like that, because I was like, wow, isn't there anything more? Like, don't we have better modalities other than medicines and surgery? And like, why is this happening to me? And so, I've had similar struggles. You shared that I'm a mom. I have 3 boys, and that's really exciting. But I'm kind of a slender person, and so I got gestational diabetes for one of my pregnancies, and everybody was really shocked about, why did you get that? And at that time I was like 122 pounds at 24 weeks pregnant, like I wasn't big, and so everyone was really shocked, like, how did you get that? And, as I learned and look back, I had all of the, risk factors. I'm, Mexican American. I was a little bit older, but I'm also, I was also eating a lot of grains, and low fat meats and beans and tortillas all the time. And that was really, I thought, protein, but it's a lot of starch, right? As we know. And so as I really came to understand that, and that's how I got into the Nutrition Network and was trying to figure out, like, how is diabetes and gestational diabetes related? And what does that mean for someone like me? And that's when I started, on this passion. And so then it just became a huge research interest. So now I actually don't do a lot of obstetrics. I do obstetrics, but not as much as, because I really feel like with all of the research and clinical research, okay, like, so I'm a scientist also, right? So
Mhm.
I don't, just say online research. Like, I do studies and things, because it's become like a huge passion of mine, and really like a big motivator of how insulin resistance can turn into poor gynecologic health. And so I think
Yeah.
that's why we're here today, and that's
Yeah,
really become my passion for medicine.
absolutely. So let's back up just a little bit. Where did you go to school?
Yeah, so I'm an osteopathic physician. So I went to
Mhm.
Western University of Health Sciences in California, in Southern California, and that was also a really incredible experience because the osteopathic approach is kind of like a more mind-body approach.
Mhm.
It's very in understanding about like how structure dictates function, and how poor functioning systems, turn into poor functioning body, right? And so that is like a wonderful help. That was a wonderful aid into like how I looked at the body as a whole, and how abnormal and insulin resistance really affects all the different organs, including our uterus.
Yeah, for sure. And how long did you work in like general gynecology before you kind of had this subspecialty interest come out?
Yeah. So when I graduated, I worked for a really large healthcare system, like in the West Coast, the biggest
Mm.
HMO, and I was doing really well, making a lot of money, but like I was super burned out and like just felt like it was cookbook medicine. And so I actually returned to my alma mater where I trained in residency, and I actually work at Loma Linda University Health. And
Yeah.
I'm laughing because like a lot of folks know this organization to be of the Seventh Day Adventists, who do a lot of
Mhm.
vegetarian and plant-based dieting, which is kind of different from what I do.
Yeah.
But they're incredibly supportive and very helpful in my journey in my research career. But yeah, it was probably 6 or 7 years out that I started realizing that there was a paradigm shift. And
Mhm.
so that's about as long as I was practicing at that time. Now I've been out for probably 15, 16 years
Yeah.
as an OBGYN.
Yeah. Yeah. Man, I feel your pain talking about the day in, day out struggles, getting burnout and just having to find a different path because if you kept going on the path you're on, you weren't going to help anybody. It's just
Mm,
kind of the nature
yeah.
these days. So you mentioned your heritage, and a lot of my viewers are not going to realize how body fat composition and storage and insulin resistance is different related to different heritages there. Can you speak just a little bit to that so they can understand where you're coming from?
Yeah, yeah. So, and I'm definitely not trying to generalize any population or anything, but a lot of Latino women, and particularly Mexican American women, tend to have a little bit more of a slender um, top, and then more kind of bottom, like kind of round around the their tummy area, and that's why there's a higher risk for diabetes in that population, because we call that what's called the diobesogenic population. And so
Yeah.
that population tends to carry their weight like in their midsection, and it's similar to a lot of Asian populations where actually in China, the BMI cutoff for obesity is 28 instead of 30, which is interesting, because of the way that they carry weight too. And so there's, and this is definitely not for all Latina people, but for a lot of us that have this body type. There's actually a couple different body types, and it's not necessarily generalized by ethnicity or race and stuff. But there's like obesogenic, which is kind of like they're round kind of all over, and then there's the slender diobesogenic, where they're a little bit thinner on top, but more they carry it like in their midsection.
Yeah, more of that visceral fat that, is around that
Mm-hmm.
area there for
Mm-hmm.
sure. So I know in my professional career, it was my personal health journey that sparked my interest in metabolic health. Got rid of, I was overweight and I had psoriasis, and that was how I kind of dove in, and it exploded from there down the rabbit hole of, oh my gosh, almost everything in this world is related to insulin and insulin resistance, and metabolic health plays a role in it. Was it your personal journey that opened your eyes to that? Because I don't think we're taught these things in medical school. We're not taught these connections. So was it your personal journey that opened your eyes to that?
It sure was, because just I got the feeling and the taste for the first time of what my patients were experiencing, and felt feeling that frustration that they carried when they walked out of the office. I got for the first time feeling like, "Oh, man, I'm doing everything right. I'm eating a low fat diet. I eat mostly chicken and grains, and some fruit. And, I don't really drink alcohol that much. And like, I don't smoke and I don't do drugs. And had a 1 hour glucose tolerance test of 200. I didn't even
Mhm.
have to do the 3 hour test. Like, that's how bad it was. And so
Yeah.
I'm just laughing because I'm like, wow, like no one taught me about this phenotype, like the way that we carry ourselves, like how the physical manifestation of that. No one taught me how that can kind of increase the risk for certain diseases and stuff. And I don't know, maybe they did. Maybe I didn't understand, but like I just feel like that's not something that like we're taught in medical school or in advanced
Mhm.
practice school and things like that. It's
Mhm.
just here's once you get like the prescription pad, right? Like you forget it, like you just become like a
Yeah,
dispensary. So
exactly. You're kind of taught how to come up with a diagnosis and then what drug do you treat it with and see you next time. And it
yeah.
became that simple. Do you remember the first patient that you used nutrition to help her GYN concerns and what that kind of felt like, to do? Because you feel rogue. The first time you do it, you just kind of feel rogue giving them nutrition advice for things like that.
I do. I do. It was a woman who came to me and she was 42 and she was obese, but she was viscerally obese, but then she became so viscerally obese that she was actually obese. And she had like all on her eyes and was crying and she came for heavy periods or no, yeah, like a irregular period. And she was so brittle and could not control herself about how bad she was feeling, just felt emotionally broken.
Mhm.
And it turned and I don't want to be like a black or white person or like this diet versus that diet, but like she was vegan at the time. And so but she had not had a period for like 12 or 2 years. And
Wow.
some of her data had showed that she was actually in premature menopause. And so she came with this diagnosis of premature menopause at 42. And then she had a bleeding episode and was just feeling super,
Mm.
messed up and drained. So we talked about the diet, and of course, I made sure that because a very good gynecologist and doctor wants to make sure they're not missing any kind of uterine cancer, so she didn't have uterine cancer and all that. And after we talked about her metabolic health and started looking at labs and things, like her period came back, and she started the treatment plan of a low carb diet. Like all of a sudden, her period came back, and so she was like, "I'm not in menopause," and so
Wait,
like
what?
yes, like, and it was so crazy that like even her numbers years ago had actually diagnosed her with it. Like it wasn't like PCOS, like it was is she actually had that met that criteria. And I just couldn't believe that her body healed itself. Like she was like, I just don't, like 6 months later, she was like, I don't even recognize myself. Like my skin is so much better. And like, I'm so much thinner and my periods are coming back and my libido has come back, and
Yeah.
so she was just so happy, and I felt like, what a weirdo. Like we didn't even give you any medicine, and like almost like I didn't give you birth control pills. What do you mean your period came back? And I was like, what the heck,
How does this happen?
How did this happen?
And by the way, you might get pregnant now, so you may need to watch that.
Yeah, that's right. Now we actually do need to talk about birth control, right?
Yes, exactly. Oh, all right. So I want to dive in to this idea of abnormal uterine bleeding because I think many women struggle at different levels of this. And most of the time they're out there floating thinking it's whatever's going on with them is just normal. This is just kind of what is supposed to happen. So if you were to describe first what normal cycles and normal uterine bleedings are so that we can know what abnormal is, give that to me.
Yes.
Describe a normal cycle
Yes.
for us.
Yes. So a normal period should be, The average age that a woman should start her menstrual cycle is about, is 12-ish years old.
Mhm.
Now it's probably getting to be around 11, but that's a whole other topic. But from 12 years old to the average age of the final period is about 51.
Mhm.
A woman, by and large, should have a menstrual cycle every 21 to 35 days. Okay.
Mhm.
And it should last about 5 days. And they should be bleeding. Get this, this is kind of crazy. They should be bleeding the amount of 2 shot glasses for the entire period, okay, which is 60 cc's, okay. So one shot glass is 30 cc's.
Mm.
Another, so two. I think like people bleed that in like 4 hours nowadays, like I just think it's
Yeah.
crazy. Like, but that is actually like if you look in the textbooks, that's what it says. Like, and if you bleed beyond that, it's considered heavy menstrual bleeding or abnormal, right? So I
Yeah.
think that would probably classify 90% of women in North America with this problem, right? It's
Yeah.
crazy. And
So
so
for viewers, a cc is an ml and 5 mLs is 1 teaspoon. So they should be bleeding 12 teaspoons. Is that right? Did you say 60
yes,
or 30?
yes,
Yeah.
60.
Okay. Yeah. So 12 teaspoons total for the 5 days.
So 5 days.
Yeah.
Isn't that
Okay.
crazy? Yeah.
Yeah.
But that's what it was like, right? And so,
Mhm.
man, how we had changed, right? Like when I was a teenager, there was no such thing as period underwear, right? There was no such thing as like overnight pads, like barely, I think barely that was even coming out. And I think I remember hearing when I was a teenager, seeing the commercials about like maxi pads with wings, like that was like the new thing. And so this, as the years are going and the generations are going, like a woman's menstrual cycle is becoming more heavy and more irregular. And so the old medical terms were menorrhagia and
Mhm.
menometrorrhagia. So menorrhagia would mean like heavy period, and
Mhm.
then menometrorrhagia would be like heavy irregular period. And
Mhm.
so though they threw those terms out back in the early 2010s, and they added a new term called abnormal uterine bleeding, AUB. And
Mhm.
then from that AUB umbrella, there's two subsets. So one would be like a structural problem, and then
Mhm.
other problems would be like a functional problem, like a hormone problem. Okay. And so, and then there's all these little classifiers underneath. It's either structural or hormonal. So structural will be like polyps or fibroids or cancer,
Mhm.
and then the functional problems would be like, bleeding disorders or infection, or being on a medication that makes you bleed more, those kinds of things.
Mhm.
And even PCOS is under that category too.
Mhm.
So it just depends on like what kind of bleeding you have. But if you're in like the 12-year-old, actually even like a little later, if you're like in the 14 or 15-year-old or 2 years since the first period to age 51, and if you miss 3 to 4 months of a period, that's not normal. Okay. And so you need to go and see your healthcare provider to kind of figure that out. And I
Mhm.
think by and large, we know as women that when there's a stressful time in our life, we'll miss a period. And a lot of ladies know that, like among our girlfriends, we talk about it like in college, like, oh, that finals week is coming up. Like, I missed my period, and everyone's like, oh, yeah, that happened to me. Like, I had a stressful time in my life too, or someone passes away, things like that. And so a lot of people know that when they're stressed, they'll miss a period, which is actually nature's way of protecting women from getting pregnant at a time that is not appropriate, right? And so remember, like our frontal brain and then our primordial brain are two different entities. And so like our frontal brain is like our rational brain. It's called like it's called our prefrontal cortex. It's where we do all of our executive thinking. And then
Mhm.
our involuntary brain, our primordial brain, where all the functions and processes that happen without us even thinking has been present for thousands and millions of years. Well, the frontal brain is like a rational brain that says, "Oh, like I'm not stressed out. Like I can totally have a baby right now, or like, oh, like I totally get what my period miss is because I'm doing all these things." But it's our primordial brain that like creates all of like the sensations and the understanding of what's going on in our environment to like actually turn off the ovulatory cycle to keep us not pregnant at a time that's maybe not safe, or a time that's maybe not right in our life, whether or not our prefrontal cortex actually recognizes that. And so that's the functional cause of like PCOS and, high insulin levels. It's all based on insulin. And so when your insulin level is really high, then that actually blocks the pathways that lead to ovulation. Okay. And so insulin is actually a stress hormone and not a like pancreatic hormone in a way that we think of, like for diabetes control. It actually is intimately related to the ovulation pathways that allow us to conceive. So when there's too much stress in our life, insulin goes up regardless of whether we're eating carbohydrates or not. It goes up because we're stressed and your body's waiting for that big stressful moment to happen. And so it blocks off our ovulation so that we don't have a baby at a time that's not right. So it's pretty awesome. So like our menstrual cycle is like the most important vital sign for a woman. It'll tell us exactly what's going on with her.
Gotcha. So should there be lots of clots, or should it be a nice even flow?
Yeah, it should be nice and even. So the way it goes is that first day is usually kind of the most painful day. And if you think about it, it's kind of like your body trying to cause a lot of inflammation to cause the contraction of the uterus to get the lining to like slough off, right? So that usually people describe that first day as like the most painful day. And then the second day is once the lining does come off, then that's the heavy flow day, okay? And that's because the lining of the uterus is raw, okay? And so those little blood vessels that created the lining of the uterus are now just open vessels, just bleeding, okay? And so you might even get like a few clots that day. And clots are normal, and as long as, they're less than this, about a teaspoon size, that's okay. And that's because that's about the size of your uterine cavity. And that's also the size of your vagina. And so if you have just some blood collecting and sitting there, it's going to eventually clot, and that's all right. So what happens is that on that second day, once the lining of the uterus sheds out, then those little raw vessels are there. And then it relies on those raw vessels to constrict and stop bleeding. Okay. And so once they constrict and stop bleeding, that's like the brown kind of light bleeding that happens on day 3, 4, and 5. Okay. So really a period shouldn't last longer than 5 days. And so, but a lot of women have a longer phase of bleeding. And the reason why is because once the lining comes off, those little blood vessels in the lining of the uterus are likely inflamed, okay, and because of cardiovascular disease inflammation. So we look at the uterus as an end organ, okay, and so we call that in medicine the end organ disease. That's because the inflammation and the high glycemia, high glucose, high insulin levels that circulate all around the body that cause heart disease or diabetic retinopathy or lung disease and liver disease, all those inflammatory factors affect the blood vessels and affect those organs. Well, that same inflammation is floating all over and affecting the uterus too. And the uterus is just one big blood vessel. It's one big uterus plus the tiny blood vessels in the lining of the uterus. And so if those blood vessels are inflamed, then they're not going to constrict as well and stop bleeding when it's time to stop bleeding when you have your period. And so those are the ladies that have like really heavy, long periods, but when you do an ultrasound on them, they're normal. Okay, there's no like fibroid or anything on them. And so that really frustrates patients and even doctors because they're like, well, then why are you bleeding so heavily? Well, it's because those blood vessels at the lining of the uterus are inflamed and they're not constricting well. There's a lot of studies on this, especially on electron microscopy, that can see that those blood vessels are impaired. So to answer your question, a period should be about 5 days, and there may be a little bit of clots, but it's usually that second day that the clots form.
Gotcha. So how does elevated insulin levels, hyperinsulinemia, lead to, you spoke to PCOS, but other versions of painful periods like endometriosis or just abnormal uterine bleeding, heavy cycles, painful cycles, that type thing? How does that elevated insulin level tie into that?
Yes. So it depends. There's lots of different manifestations of this, and it has to do with basically all of the different gene collections in your body and how they enable those high insulin levels to be expressed. Okay. So for some women, that looks like just heavy periods because the blood vessels at the lining of the uterus are so inflamed. And that usually is a woman who is peripherally obese, like a woman who carries her weight everywhere. Okay.
Okay.
And that blood vessel inflammation at the lining of the uterus makes the lining of the uterus grow thicker and thicker and thicker. And we also see that with PCOS. That increases a woman's risk for getting cancer of the uterus. Okay. Now, because of all the extra tissue and the fatty cells of her entire body that are making the estrogen increase and grow and make those linings grow in the lining of the uterus, but also from the ovaries too. So our fatty tissue also secretes estrogen. So that increases a woman's risk for uterine cancer later. Then there are some people who that high insulin level can cause inflammation and tissue damage at the uterus, at the body of the uterus, and cause uterine fibroids. Okay. And that is usually a woman who is more viscerally adipose, so like the fatty tissue in their tummy, but slender on the top. And so I'm actually doing a study right now looking at women who had hysterectomy and measuring their CT scan and measuring their visceral adipose tissue before they had their hysterectomy. There is a lot of data on that, but I want to do something newer and see how does this relate to insulin levels. But so yeah, so it's because the insulin level, but also the high glycemia. So a lot of the things we think of is that women who are viscerally adipose tend to not process glucose as well as women who are peripherally obese. And so what it's showing is that women who are peripherally obese, their high insulin level is doing what it's supposed to. It's storing their fat in their fatty tissue. But women who are viscerally obese, they have higher glucose levels because for some reason their insulin is either not high enough or it's not bringing in the glucose into their fatty tissue peripherally, just into their abdomen and their end organs. And so these are the women that tend to get diabetes, but they're also the women that tend to get uterine fibroids because of the circulating damaging effects of high glucose and either high insulin or not enough insulin. And that causes a lot of body inflammation that can lead to uterine fibroids, which is what we actually refer to as like cardiovascular disease of the uterus, okay, which is very interesting. It's like atherosclerotic disease of the uterus. The same cells that produce uterine fibroids are the same ones that cause hardening of the arteries, which is fascinating. Yeah. And so that's really interesting too. So that's like, well, that's another mind blower, right?
Yeah, I was actually that was on my list of things to ask. Do we get calcification in there just like we get calcification in other places? But
yes, and we've known this. We've known this since the 1960s. In fact, the paper you were asking me about earlier, the reference is there, and where we see that the same myocytes, the same muscle cells that line the blood vessels are the same ones that line the uterus, and so they're called smooth muscles, and so they react in the same way. So when you get hardening of the arteries from calcifications in the peripheral circulation, that same thing is happening in the uterus. And it's also, so that's what fibroids are. So fibroids are atherosclerotic disease of the uterus. And so if you've got those, then you have a really high chance that you probably have it everywhere else too, and so it's a risk factor for cardiovascular disease with that's been very established. And so, but we don't look at it that way, right? We, in gynecology, we're so good at medicines and surgery, and rightly so, because sometimes fibroids can cause women to bleed very, very heavily, and we need to remove it with surgery. We need to give medications and blood transfusions and stuff. And that's all good. But a lot of folks just feel confused about like, why do I have this? And there is genetics involved because it just depends on how your body processes this. But a lot of the short answer a lot of patients get is like, it's your genes. Okay, let's remove it, but, and then there's endometriosis, right? And endometriosis, as we learned at Low Carb Boca, is a gut microbiome disorder, and where basically your intestinal healthy bacteria gets impaired from a lot of processed food, and I see mostly like smokers and people who eat a lot of soda and fake foods and stuff that really damages like their intestines and causes breakthrough of the connections. It leads to inflammation. That inflammation goes down into your pelvis and sits there, And then when you have a period, that bleeding goes through the fallopian tubes and sits in that area of where that inflammation is. So the bleeding comes out the fallopian tubes, the bleeding comes out through the vagina when you have your period, but it also comes out through the fallopian tubes. And then it just sits in that area, and it causes new blood connections, leading to endometriosis. So that's really interesting too, you know. So however your body manifests, right?
Yeah, but normally, so every cycle we have blood that comes out of both places. But if there's not the inflammation there, the body will just reabsorb, take care of it, and be gone away. But if you've got that extra inflammation in there, it sets up the endometriosis, which is essentially uterine cells outside of the uterus that can bleed and cause inflammation and pain and all kinds of stuff after that.
Yes. So like those uterine cells create new connections in the pelvic cavity and around the intestines because those inflammatory factors to clean up the gut dysbiosis, like the leaky gut that was there, were already present. And so then when the uterine cells go there, then some of the factors that are there in that inflammation are what we call vasoactive factors that allow for new blood vessel connections between the uterine blood vessel or the endometrial blood vessels, the lining of the uterus blood vessels, and the pelvic cavity. And and then when they establish that new connection, then those cells become active again. And then they respond to hormone influence just like your period. And then they bleed just like you're on your period, but stuck to your ovary or stuck to your intestines or stuck to your rectum. And so then that's why that pain is so heavy and so uncomfortable when women are on their period for that reason, because those cells are bleeding just like as if they were in the lining of the uterus. They're just like responding the same way. So it's fascinating. There's so much here, right?
There really is, and so much that is just a foreign concept to most everybody. So you mentioned end organ, and I don't know that my user or my listeners are going to understand what an end organ is. So explain what you mean by that and how the uterus qualifies as an end organ.
Yeah. So that's kind of like a doctor term, and it's hard to kind of like you know to translate that completely. But what I will say is that our body has a circulation. And so all the blood vessels go to the major blood organs in our body, our eyes, you know, our heart, our lungs, our kidneys, our liver, our ovaries, our uterus. And so whenever your body is under a kind of inflammation, that inflammatory factor is going to circulate all over. So it doesn't just go to one organ. When we think about smokers and they get chronic obstructive pulmonary disease because of that inflammation in their lungs, that smoke doesn't just go to their lungs. Okay. It goes to their heart. That inflammation goes to the other organs, and it goes to their uterus. When we think about diabetes, that high glucose doesn't just go to, your kidneys, and when people think about, diabetes and dialysis patients, right? Or infections and stuff, that high glucose level that leads to all these problems goes to all the other organs, including the uterus. Okay. And so I think that's why this is such an important topic for me, because I would also like to normalize women's health and not silo the problems of menstruation and periods as like hormone problems, right? Because don't you think, Amanda, sometimes that term can be kind of derogatory for us women, right? Where it's like, it's not really our hormones, and it's like we're kind of feeling the same thing that men would feel, but it's just manifesting differently, right? Like our menstrual cycle is just our manifestation of metabolic dysregulation, right? Like a lack of metabolic health, right?
Yeah.
And so if we frame it that way, then it doesn't feel like something's just happening to us because of our gender, right? And so the end organs are all of the organs at the end of the circulation, okay? And all those organs are the organs that receive the inflammation, and get those problems, those diseases that we think about. And so the uterus, for many years, it has been historically not considered an end organ because we're thinking about it in terms of estrogen, progesterone only. Okay.
Mhm.
And it's like a different silo, but that's not really true. Yes, it receives inflammation just like any other organ would because it's part of the circulatory system. Okay.
Mhm.
But it's also influenced by estrogen and progesterone as well.
Yeah, for sure. And when women come and they think it's their hormones and that whatever is going on, my hormones, it's my hormones. It's like, okay, it is, but it's not just your sex hormones because they
Yeah.
all intertwine. Your body is made up and controlled by thousands of hormones or hundreds of hormones, and it's not just that one. So you've got the hormone insulin that acts on your other hormones, and it's all connected. So it's not just about the lack of progesterone or estrogen or whatnot. Now,
Right.
when we were
Wow.
in Boca, you made a statement and you've alluded to it earlier about the uterus being a reflection of the cardiovascular system. This is Heart Awareness Month. It's in February. We're trying to alert to the importance of being aware of your heart health and screening. But elaborate a little bit about how the uterus is a vascular organ and can be a warning sign as to other vascular problems in your body.
Yeah. So, gynecologic health is cardiovascular health. Okay.
Mm.
And I think that's like even one of my lectures for the Nutrition Network. I think it's even called that because gynecologic health is the most important indicator and actually the earliest indicator of impending cardiovascular disease in women. Okay. It just depends on how it's manifested. And the most important signal for that is a woman's menstrual cycle. Okay. Because your uterus is made of the same blood vessels that all the other blood vessels of your body is made of. In fact, it's only made of those blood vessels. Okay. And so if you're having heavy periods, then that we know that those little tiny blood vessels that should be constricting when you do have your period are impaired, they're receiving inflammation. And what better place to get an indication of how our cardiovascular disease health is by the uterus, which is remodeling itself every month. Okay, the lining of the uterus is shedding every single month. And so that means that those blood vessels have an opportunity for regrowth and healing, kind of depending on what our metabolism is doing. It's
Mhm.
also an incredible indicator of what insulin is like in our life, okay? Because when we have high insulin levels, that actually blocks off ovulation because your body feels like it's under a stress. And
Mhm.
then that high insulin level will then allow your ovaries to produce more testosterone. And
Mhm.
then that testosterone goes around our body and for some women causes hair where they don't want it, like in their chin. Some
Mhm.
people get it as acne. Some people get it as like darkening on their neck. Some people get like just more prominent follicles on their private area or on their abdomen. And so, that's kind of like the PCOS picture. And so basically I talked about inflammation as like uterine health, but I also talked about high insulin levels and PCOS as the endocrinologic component of that. So that is the essence of cardiovascular disease, high insulin and inflammation, right? But that's how it manifests for women. And isn't that cool? I mean, I just feel like we're reframing the conversation of what women's health really is, right? And it's not like, oh, poor you over there with your period. It's like, no, like this is perfect because then we can like learn about that and prevent diabetes and hypertension and all these problems later as a woman gets older. But gosh, like when you're in your reproductive years, like there's so much opportunity for improvement. And so I think birth control pills are like such a great thing for birth control, but not to cover up necessarily without having a conversation about it with the patient about how is this treating your menstrual cycle. It does help. It's very life-saving for some people who have crazy heavy periods. Like hormonal birth control options are incredibly helpful for women who are not maybe in the place to like change their diet. Maybe they've got 3 jobs, and a bunch of kids and like or 1 kid, right? And like meal plan and all that stuff. Like it's helpful, um, for a short amount of times, or even a long amount of time. It's very helpful, but you have to teach women how they got there and then they can decide how they want to manage this, right? If like have the tools in their toolbox and the bandwidth to change their diet and lifestyle, awesome. That lifestyle is always the first way to go, right?
Mhm.
Lifestyle, medication, and surgery if needed, right? And that's what I always present to my patients is like, okay, we got this problem. I taught you how you got here. How do you want to proceed, right? And I
Yeah.
think that's the very essence of whole person care.
Yeah, absolutely. Man, you kind of summed it up. I was going to ask you to leave us with hope, but you kind of did anyways. It's just, you know, it is within a woman's power to make changes and to change the course of their life, no matter where they're at in their journey, whether they're in their 20s, 30s, 50s, 60s. It's within their power to make changes, and it can be very impactful. Thank you for joining. Please tell my viewers how to find you on your social media and how to connect with you down the road.
Yeah. So I do have an online telehealth practice. So if you happen to be in Florida or California, I'm happy to see you in a telehealth capacity. My website is called consciousgynecologist.com. But then I also have an Instagram account called Conscious Gyne, and I have a YouTube channel called Conscious Gynecologist that I update weekly with lots of really different information that we talked about here. And it's a lot of fun. And then I've got some clinical research and stuff. You can check that out too on PubMed and Google Scholar. And so yeah, a lot of different ways to find me.
Absolutely. And I highly encourage people to go to your Instagram and your YouTube and check it out. There's been some great videos on there that you can learn from and share with your girlfriends, your friends, family that are also struggling so that they can get that same message of hope. And spoiler alert, it's not spoiler, it's on the website. But Dr. Salcedo will be joining us at Low Carb for Better Health this year in September. So if you would like to meet her in person and hear her speak September 12th and 13th, please go to lcforbh.com and grab your ticket so that you can meet her in person and connect and chat with her there. So thank you again for joining me. Thank you for your time. And everyone else, I will see you next Tuesday.
Yay.